Now, the story of Alzheimer's disease began more than 100 years ago. And that was the early part of the 20th century. And a concerned husband brought his wife, around 50 years of age, named Augusta, to Frankfurt Hospital. And in that hospital, the consulting physician at that point of time was Dr. Alzheimer, and that was actually 1901 to be precise. And 5 years later, down the line, the Augusta died, and Dr. Alzheimer was quite fascinated by that case, and he decided that he would do brain autopsy of that lady. And when he did, he found a lot of fascinating riddling pathologies in the brain of that lady, Augusta. He got a lot of tangles, a lot of plaques, and he published his paper, which later the disease was known as a case of Alzheimer disease. This is the beginning of the story of Alzheimer disease, and the most fascinating aspect of this is that even after 100 years, still whatever Dr. Alzheimer had found in the brain autopsy, that stood the test of time. Actually, those findings are considered as a gold standard even in the diagnosis on the brain autopsy for Alzheimer disease. Now, Alzheimer disease is the most common cause of dementia in the elderly population, and most often we confuse dementia with loss of memory, but dementia is much more than that. Dementia basically means progressive acquired deterioration of your cognitive skill, which impairs your day-to-day activities. That means, firstly, your cognitive skills should be impaired. You should have loss of cognitive skill, and that should be progressive acquired deterioration of that. And cognitive skills not only means memory, it means a lot of other things. It means your reasoning ability, your thinking ability, your calculative ability, your visuospatial abilities. All these things together, they comprise your cognitive skill, and that should be progressively deteriorated, and that must impair your day-to-day activities. That there is a classic definition of the dementia, and there are many causes of dementia. Actually, there are vascular dementia, could be due to infarction. There could be frontotemporal dementia. There could be Parkinsonism associated dementia, Lewy body dementia. There could be vitamin deficiency associated dementia, like vitamin B12, vitamin B1, vitamin B3. There could be hypothyroidism associated dementia. These particular vitamin and thyroid associated dementias we call reversible dementia. Then there is another term called pseudo dementia, which is typically associated with depression. But the most common cause of dementia, actually, in particular in the elderly population, is definitely Alzheimer's disease. Now, Alzheimer's disease is associated with a lot of risk factors, and the risk factors are, most important risk factor is aging. More you age, there is higher chance of developing Alzheimer's disease. Then there is also associated with increased risk of female sex. That means if you are female, then you are obviously more at risk of developing this thing. They have found this in studies. Another thing is that the most important aspect that you like to say is genetics, and then there are 4 important genes they have found are associated with the risk of developing Alzheimer's disease. Those 4 genes are APP, amyloid precursor protein, presenilin 1, presenilin 2, and the last one is apolipoprotein E. And here I want to clarify this, that the most important genetic risk factor altogether for the development of Alzheimer's disease is definitely apolipoprotein E. This is the most significant, most strongest genetic risk factor. And many times people confuse that APP gene mutation is the most common risk factor. That's not. APP gene mutation is actually associated with less than 1% cases of Alzheimer's disease. But this one is associated with much more than that, at least 40% or even more than that. At this point, I would also like to mention that there's a way to classify Alzheimer's disease. One is called early onset Alzheimer's disease, and this is called late onset Alzheimer's disease. Early onset Alzheimer's disease typically developed from 30s to 60s, and late onset, which is the most common type, typically develop after 60, 65. And majority of the cases, around 90 or more than 90% cases, are late onset Alzheimer disease. And for this group, late onset Alzheimer disease, the most strongest genetic risk factor is mutation in the apolipoprotein E on chromosome 19, particularly the epsilon 4 allele of the ApoE gene on chromosome 19. And for the early onset, those three genes, which are early onset, which is a minor group actually, comprises less than 10%. Those three genes are there: presenilin 1, presenilin 2, and amyloid precursor protein. Now, coming to the pathology of Alzheimer disease, there are certain things which we see microscopically. The first point I would like to mention that typically the atrophy, we see the cerebral atrophy is a shrinkage of cerebral matter all over the brain, but particularly it starts in the medial temporal lobe, particularly in the entorhinal cortex and hippocampus. And hippocampus is the place actually where your early memories get stored, your recent memories. So that's why as the hippocampus affects very early, that's why the typical presentation of Alzheimer disease is loss of your short-term memory. That is the usual presentation. And microscopically, when we look at Alzheimer disease, then there are two key things are actually seen. One is the presence of amyloid plaque or neuritic plaques, and second is neurofibrillary tangles. Nowadays, they have found that amyloid disease is much more than this proteinopathy. But in this discussion, I want to concentrate and focus on these basic things actually. Now, what is neuritic plaque? Neuritic plaque is that there is an amyloid core, which is I would say, toxic, abnormal form of amyloid, which get deposited in certain parts of the brain. And this amyloid actually originates from APP, amyloid precursor protein, which is located on chromosome number 21. And we all have APP. But in the patients of Alzheimer disease, what we see that from this precursor protein APP, a particular length of protein, is typically 39 to 42 amino acid length, that gets chopped from that big protein, actually the APP, amyloid precursor protein. And this 39 to 42 amino acid length is called beta amyloid proteins. They are quite sticky. They stick to each other and they form some oligomers, aggregates. And these aggregates are actually, they act as a neurotoxin kind of thing. You can think in this way that you can think the whole brain as a children's park full of grasses, green grasses, full of greenery. And somebody at night, they dump some garbages at some places in that children park over the grasses, and the surrounding grasses start to die. So this is an analogy I would like to tell in this case. That means just like this, as some part of your brain, this abnormal form of beta amyloid proteins, they get actually deposited, the surrounding neurons, they start to degenerate and die. And this structure, where at the core, at the center, there is beta amyloid, and surrounding there is a dystrophic neurites are there, we call this structure neuritic plaques. Another structure is also seen, that is called neurofibrillary tangle. The previous structure which I mentioned, that is the neuritic plaque, is extracellular, because amyloid typically gets deposited extracellularly. But this neurofibrillary tangle, usually, initially at least, is seen in intracellularly. And this occurs due to an abnormal form, hyperphosphorylated form of tau protein, tau. Now, tau is a microtubule associated protein which helps in structural integrity of the axon. Now, when this tau gets hyperphosphorylated, abnormal, the axon loses its structural integrity, start to degenerate, start to die, and it has also found that they have some toxic effect. And it leads to this deposition of this plaque, neuritic plaques, amyloid plaques, and deposition of these neurofibrillary tangles. They cause widespread degeneration of the neurons all over the brain actually. So Alzheimer disease is basically a classic neurodegenerative disease. And if you look at the various pathogenesis of the various neurodegenerative diseases, they have a basic storyline actually. The storyline is that they all have some form of abnormal proteins, and these abnormal proteins get deposited in the brain and has some kind of toxic degenerative effect. In case of Huntington disease, this is huntingtin protein. In cases of Parkinson's disease, could be alpha-synuclein protein. In case of Alzheimer disease, there are two abnormal proteins I mentioned, beta amyloid and tau protein. So there will be always an anti-hero, villain protein is there, which is causing the problem in cases of neurodegenerative diseases. This is a key aspect you need to know. Another third aspect morphologically is that you can see the presence of cerebral amyloid angiopathy. That means the deposition of amyloid in the blood vessel wall of the patient with Alzheimer disease. And lastly, a very important point I would like to mention, that amyloid Alzheimer disease is typically associated with an abnormality of neurotransmitter. If Parkinson's disease is a problem of loss of dopamine, then Alzheimer disease is basically they have found there's a loss of acetylcholine, and particularly one area of the brain, nucleus basalis of Maynard, there's this full of cholinergic neurons, and as they get degenerated, there's a loss of acetylcholine. And that's one of the, if you look at Alzheimer disease from the perspective of neurotransmitters, then the basic problem is loss of acetylcholines they have found actually. And another point which I would like to mention, that sometimes we need to understand, that is Down syndrome patients, trisomy 21 patients, they usually have a very early onset Alzheimer disease. They can, if they survive beyond 40, they can develop Alzheimer disease. The reason for this is that the location of APP chromosome is on chromosome 21, and normally we have two chromosome 21, but Down syndrome, as it's a trisomy 21, they develop abnormal protein, amyloid proteins, at much faster rate. It's like two factories are producing some abnormal proteins. Instead of two factories are replaced with three factories, and if two factories are requiring 60 years to develop that amount of abnormal protein, two factories would require much less of time, actually 40 years, and that's why usually they have early onset of this thing. So in summary, Alzheimer's disease, I would like to say that this is the most common cause of dementia in the elderly population. There's a widespread atrophy of the brain we see. There's a widespread atrophy of the cortical matters. Typically the problems start with the medial temporal lobe. Morphologically we see three key things. One is neuritic plaques, second is neurofibrillary tangles, and there is an abnormal deposition of two abnormal proteins, that is beta-amyloid and tau protein is seen. And another important aspect is that nowadays they have found that it is also associated with chronic neuroinflammation in these conditions. And there is also an important angle from the neurotransmitter. This condition is usually associated with loss of cholinergic neurons due to resulting in the loss of acetylcholine. So this is basically the pathology of Alzheimer's disease in a nutshell.